They get more blood loss, especially on dialysis, but also because doctors, we tend to take blood all the time from them, and that doesn't help. But they also lose blood because they bleed. And one of the things that happens when you get kidney failure is that you get very high acid levels and hormones in the stomach, which makes you more likely to get stomach ulcers. They get iron deficiency, and I'll talk a bit about that. And of course, erythropoietin, that wonderful hormone, is actually produced by the kidney. So as the kidney gets worse, it gets less. And so you need that to produce blood. Another big thing is infection and inflammation, which is more common. And of course, people with kidney failure don't like to eat and don't eat well. So they don't get the necessary vitamins and iron that's required. Now, this is a really complex diagram, and the only thing I want to highlight here is all about iron. Normally what happens, you take iron in your gut, and then that's absorbed into the blood, and then that's used to make more blood. The problem is when you've got chronic kidney disease or any disease that causes inflammation, so heart disease, chronic diabetes, chronic infections, and plenty of our patients have many of these, that produces a hormone called hepcidin from the liver. And that's not good because that blocks your ability to absorb iron from the gut, hence why oral iron often isn't as good, but also your inability to get the iron which you store in various parts of the body. So you can't extract it and you can't absorb it. And that's one of the reasons why we've changed the way we practice. So why does iron deficiency matter? But again, this is a really complex diagram, but I just want to highlight one major bit of understanding which we've been working on for the last decade. We all know that iron is very important in making blood cells because iron gets put into each red blood cell, and that's all about transporting the oxygen to where it needs to get at, so the tissues. But the problem that we fail to recognize is that even though you get the oxygen to the tissues, it needs to be used, so extracted. And that's where the mitochondria come in, these little powerhouses involved in all cells. And they require iron because you've got these iron sulfur clusters in the mitochondria. So if you don't get patients iron replete, so have enough iron, they won't feel better even though their hemoglobin is slightly higher. So you have to have the combination of the two things to be effective, and that's really important. And I'm just going to show you one animal study, which we've been doing, and we've now done it in humans as well. And what I want to show you, these are the mitochondria. And this mitochondria on the left looks ill, whereas you can see this one really densely packed is healthy. And what's happened, this one's got kidney failure and is iron deficient. And this is what happens when you replete the iron. And the graphs show you what happens. The blue one is the dummy animal, and the orange one is the kidney failure animal. And as you can see down here is when you give the iron to the rat, you inject it through the tail vein, you can see that restores the ability of the mitochondria to function. And you can see here these lovely images show that what happens to the heart. You can see that our heart lights up and is functioning far better when you give them more iron. And that's really showing you how important it is to correct the anemia to improve how well your heart functions, as well as your other muscles, such as your legs and your arms. It may also translate into making you think a bit better. So sometimes you get this brain fog. So I love that. I always like this slide to say that if you're iron deficient, it means you're running out of fuel. And it's just like that. That's what people feel like. They lack the energy because they've got no fuel, and you need to replace it. And this just shows you what happens in humans. I just want to focus on this. If you give patients iron, these are patients with heart failure, with renal disease, you can see that giving them iron, they can walk further. This is the 6-minute walk test. So on average, you can walk 30 meters more just by giving iron, and that's independent of the level of hemoglobin. Oops, sorry. And this just shows you also some data from our lab and our patients showing the other thing that we've demonstrated. And this is one of the key things, is that by giving iron, the one in the red, you can see that these patients feel better. Their SF36, which is a quality of life score measuring how they feel, their tiredness, their mental state, these all improve by giving iron, demonstrating that iron and correcting anemia has a huge impact on quality of life. And this really, I'm going to miss this slide out, but I really was just trying to demonstrate that quality of life is one of the key factors related to anemia. And if you correct it, you improve quality of life. The other thing, of course, we want to do is that if you improve anemia, this is data from our over 1,000 patients, that you actually reduce death rates. So these are patients with no anemia and no renal disease. And these are patients with anemia and renal disease. And as you can see, if you have more anemia and more renal disease, you're less likely to survive. Whereas if you correct the anemia, it improves your outlook and you will live better and longer. So what about the symptoms? And that's really important for use. This is just really some things which you complain of. This idea about feeling tired all the time, looking very pale, your tongue gets very bright red and blue and quite painful because you're iron deficient. You get this what's called angular stomatitis from iron deficiency, and that's really quite painful. Again, there's this pallor, and your nails become spoon-shaped. Of course, if you're anemic, then you can get chest pain because it affects the heart. And that's really important for us because a lot of patients with kidney disease have heart disease. And of course, there's this idea, this mental fog which people get. They just can't function, and we want to try and improve that. And also, some people don't recognize that iron deficiency, in particular causing anemia, causes hair loss. And that can be quite devastating for some people when their hair just falls out. And it's something we can easily correct. The big thing that I want to highlight is this idea about your brain function and depression. And that's something that really we overlook, that iron deficiency and anemia has a huge impact on how our brain functions and getting depressed. And that's something we really need to focus on more. And we're doing some work currently trying to assess this, if we can improve this by improving the iron deficiency and improving the hemoglobin levels. The other thing, of course, is that where a lot of people complain about, especially the dialysis patients and those with bad kidney disease, is getting restless legs. Their legs jump all the time, especially at night. And actually, the commonest cause of that is iron deficiency anemia. So simply correcting that can reduce those symptoms of restless legs, which trouble people a lot and stop them sleeping at night in particular. And as I said before, you can see here, what are the benefits of correcting anemia? Well, we improve quality of life. We improve exercise capacity. We actually improve sexual function, which is really important. It improves endocrine function and the immune function. So it actually gives added defense for infections. And that's particularly important in the era of COVID, where we know that renal patients are particularly more at risk. It reduces depression, and it actually reduces bleeding tendency. From my point of view, it stops patients coming into hospital, and that's good because that means less time away from their loved ones, more time if they're still working, and less disruption to their life. It reduces the number of blood transfusions that you require, and that's really important because you know for every blood transfusion that requires, it produces antibodies. And many patients will require a kidney transplantation, and the last thing we want to do is transfuse them and then make it more difficult because they get antibodies, which makes transplantation more difficult. It has huge benefits on the heart, so it reduces cardiac disease. And you may know that we finished the pivotal study, the largest study in the world in dialysis patients, in over 2,000 dialysis patients, which showed that giving higher doses of iron during dialysis reduced mortality, cardiac events, heart failure hospitalizations. So really important. So the last bit is really, how do we tackle anemia? And there are many guidelines around the world which suggest what we should do. But really there are 5 key areas. As I discussed, iron, giving you intravenous iron, either giving it in the diet, which is not as good because of the absorption, giving it orally, and there are a few new oral preparations coming out. There's ferric maltol, which is meant to be absorbed better and cause less side effects. There's ferric citrate, which again is a phosphate binder, but is suggested to be beneficial with less side effects. And of course, there's intravenous iron, and that's what we use mainly in the UK in our patients because it's convenient and it's a one-stop visit and it's very infrequent. Once you've given them iron and repleted that, the next step is to give them erythropoietin, and that's given either as an injection into the skin or intravenously, especially during dialysis. And that we use long-acting treatments in the UK because you can give them every fortnight or every month. And that's really important that once you've replaced the iron, you give them erythropoietin. You may need more iron when you're on it to replete it, but that's been a step change. As I say, there are blood transfusions in critical situations, but we tend to avoid that. But there is really the new kid on the block, and that's the hypoxia-inducible factor. And these were drugs which have been developed initially from Oxford. And these are drugs which try to mimic in producing erythropoietin. The ESAs are synthetic, but these new drugs are given as tablets and they make your kidney and liver produce erythropoietin, so it's more physiological. These drugs currently are still under trial. They're available in China, but not yet in the UK, and I don't think Europe either. But that's a drug to watch because it might be a more physiological way of correcting anemia, as well as improving your ability to absorb iron and use iron. And finally, there are a few novel therapies out which are coming out and are still under research. The key here in treating patients with anemia is that it's individualized care. Not everybody is the same, and we've got to treat them as an individual and try and cater to each person. And we also have to acknowledge that any treatment has side effects, which we need to be aware of and balance the risks from the benefits. So really, just in summary, there are plenty of benefits. Patients say to me, I feel better, I can do more, I'm less tired and lethargic, I have more energy. It's less disruption to their life, reduced transport requirements, less injections because they give it intermittently, and it saves time as well as making them feel better. So I'm just going to finish there and say that hopefully I've shown you that anemia in chronic kidney disease is common. Nutrition is important and impacted by social factors, which I didn't mention. But anemia has huge impacts on quality of life, the ability to function, this idea about brain fog and depression, heart problems, and potentially progressing kidney disease. But correction, it can improve some of these, but not necessarily all of these. Thank you.
Thank you very much, Mr. Bandari, for your enthusiastic and good talk. We have some questions.
Yep. So I can see the first question. If a patient is on oral iron, what symptoms could be a signal that disease is not managed? What dosage of oral iron is also indicative of this? As I said, the problem with oral iron is absorption and tolerating it. About 40% of people get either some heart problems with their stomach, they get bloating, or they get diarrhea, or they get constipation. In terms of what dose you use, there's a lot of controversy. Before, there used to be a standard dosing of 3 times a day. But some new data, which is a very preliminary, suggests that once a day might be better as you'll get better absorption, but that needs to be researched. And more than likely, to get enough iron on board, you'll probably need to take it for a long time because it will be absorbed, but not as effectively. So I think for us in our unit, we tend to use intravenous because it's simple. But if you're going to use oral, you've got to be aware that there will be symptoms and that you'll need to take it for a long time. The other thing to remember, a lot of patients are on other tablets, and iron is absorbed when the stomach has got a very acidic environment. And some patients are on drugs such as proton pump inhibitors, so lansoprazole or ranitidine, and that affects the absorption of iron. So be careful when you take the iron, you don't mix it with other tablets. So the next question I can see here, is depression a function of the disease or poor quality of life? That's a great question, and I think we don't know that. I think because kidney failure has got so many symptoms, and our next speaker will probably share that with you. There are over 250 toxins in kidney disease. I think we don't really know what causes depression, but we can say that anemia is one part of it that we can fix, and that might help, but it may not solve the problem, and it may not fix everything. What are the benefits of a physiological way of treating? So I think the benefits are, we know that giving erythropoietin synthetically, that the data has shown that we shouldn't increase the hemoglobin too high because that increases risk. And that's because when you give somebody an injection of erythropoietin, you get very high levels in the blood. And that's bad because it increases blood pressure and it can cause adverse events. Whereas the data giving it using using endogenous, so you give somebody a tablet and they produce their own erythropoietin, it's more in a physiological range. So you get a gradual increase in hemoglobin and no detrimental effects. In addition, actually, it improves iron absorption. So I think being more physiological is always the way to go. Thank you.
We also have a few questions in the chat function.
All right.
The first one is what is the best level of iron in the blood? Is it the iron or is it hemoglobin?
So there are two different things. Hemoglobin tells you the amount of blood. If you want to measure iron, you want to measure ferritin or transferrin saturation, those two. But realistically, they'll tell you how much iron is there. So you need the combination to know if your hemoglobin's good and your iron's good.
Yes, you have already said that. In which form you can add the iron in the best way?
Yeah, so I mean, clearly there's new preparations coming out, and the ferric, the Fe3 plus, might be the better way in terms of absorption. So new data to follow, hopefully in the next year.
Okay, thank you. If a patient is on oral iron, what symptoms plus oral iron could be a signal that this disease is not managed? What doses of oral iron is also indicative of this?
So I don't think anybody knows that. We measure to see whether they've had a response in the blood tests. If they haven't had a sufficient response, they're probably not getting enough iron or they're not absorbing enough iron. So then you might want to switch to intravenous. The symptoms will stay. So your symptoms of iron deficiency anemia will persist. And that suggests to you that the iron's not working. So I think we've answered that third question. So what type of treatment do you provide your patients to address their iron deficiency? So in our unit, for all our dialysis patients, we use regular intravenous iron. For our chronic kidney disease patients, we use intermittent intravenous iron. We don't use much oral iron now because it's simpler just to bring them in for an intravenous iron. And usually they need between 2 and 3 doses of intravenous iron per year. So that's simple and easy for us. And that's what we tend to do because most of our patients won't take the oral iron because they don't tolerate it.
Okay. And then the next one, could greater attention to kidney anemia improve the likelihood of labor integration of kidney patients?
Absolutely. If patients are feeling better, they can do more because they can exercise better, then they will maintain in their work. And that's really important because having structure to your life and having work, I think, is really important to try and have normality. So I think the better we can make them feel by normalizing their blood counts, the more likely they are to function better and be able to do their work.
Okay, thank you so far. We are on half time and we go to the next speaker, Dr. Emilio Sanchez. He's Chief of Nephrology in the University Hospital of Gijón in Spain. And he's a specialist in nephrology and transplantation, but also in the bone and mineral disorders. And his talk is called Advances in Treatment of Uremic Pruritus. I want to ask you to start your presentation, Mr. Sanchez.
Hello, good afternoon. Could you see my first slide?
Yes.
Okay. First of all, I want to thank for the invitation to participate in this meeting. It is the first time that I participate in an event by this association. It is a sort of pride and satisfaction for me that the Patients Association invite me to make a presentation. I really think that doctors work for patients and that patients count on you for this type of activity is very pleasant. To begin this talk, we are going to focus on a problem that is common in the population with chronic kidney disease. It is about itching, especially chronic itching. We can define it as an unpleasant sensation on the skin, leading to a desire to scratch, with symptoms that are present for more than 6 weeks. We prefer to use the term CKD-AP, chronic kidney disease associated pruritus, since the word uremic can make us think that the itch is produced by accumulations of toxins in the patient with renal failure. But really, the etiology is multifactorial. The causes of chronic itching are very varied. There are specifically dermatological problems such as atopic dermatitis or psoriasis or some others. Some neuropathic problems such as post-spretic itch, brachioradial pruritus, for example. Psychogenic, and finally, some systemic diseases as primary biliary cholangitis and the chronic kidney disease as the most frequent. A diagnosis of CKD-AP requires exclusion of other potential causes of itching. When a patient complains of itching, we must do an examination to verify the presence of visible skin lesions. In the event that this happens, we should think of a dermatological disease itself. If we do not appreciate these lesions and the patient has chronic kidney disease and there is no other underlying cause that can produce it, we can think of the entity called chronic kidney disease associated pruritus. The pruritus associated with chronic kidney disease is often bilaterally symmetrical and can be localized or generalized. Here you can see the skin lesions most frequent seen in the patients with chronic kidney disease and comes from scratch marks with scoriations to prurigo nodularis or deep scars. It is important to know the incidence of chronic kidney disease-associated pruritus. For that, we are visiting the DOPS study, a study that analyzed problems and dialysis schedules of hemodialysis patients in various countries around the world. In relation to itching, they estimate that in moderate to very severe forms, it can affect 40% of the population on hemodialysis. After a reduction in the percentage of patients suffering from the most severe forms, thanks to the generalization of online hemodialysis filtration and the general improvement of the technique, it remains in a plateau phase. There is still a wide margin of improvement. It seems clear that much of the itching is not mediated by the presence of uremic toxins. A problem added to the pruritus itself is that we do not have adequate tools for diagnosis. If we add the treatment we have are not very effective, the result is that an underdiagnosed problem. According to the data from the DOPS study, less than half of patients report the presence of itching to their nephrologist. It may also be because they don't think it could be something to do with their kidney disease or dialysis. A significant number of patients talked to the nurses of general practitioners about this problem. An additional conclusion of the DOPS study is that almost 70% of the nephrologists surveyed underestimates the prevalence of pruritus in their dialysis units. CKD-EAP is not only important because of how unpleasant it can be, it is also because it reduces the quality of life, worsens the quality of sleep, increases the risk of mortality, induces the onset of depression, and increases the healthcare costs. All these problems that orbit around the itch must be taken into account in its evaluation. Chronic kidney disease, especially those in hemodialysis, suffer from poor quality of life. This situation worsens even more in the presence of itching, at least in the more advantageous stages. This study shows that the greater the intensity of the itching measured by two commonly used scales such as Skindex 10 or the Brief Itching Inventory, the worse the quality of life of these patients. The SF36 Quality of Life Questionnaire consists of 36 items grouped into 8 dimensions. In this study, in which 200 patients were included, it was found that those patients with itching gave lower scores in all dimensions, clearly reflecting their lower quality of life. CKD-EAP not only reduces the quality of life, but also produces alterations in other areas. Thus, the presence of itching is seen to alter the emotions and make them frustrated or embarrassed, as can be seen in the results of the study that included more than 1,000 patients. Those with more intensity of itching feel more annoyed, frustrated, or embarrassed. These emotional states can interfere with patients' ability to work, appearance of social life. Look at this graph that shows how patients are affected by their appearance, feel depressed, have troubles working, or avoid social contacts. Patients with more severe levels of itching are severely affected in all these aspects. Most CKD-AP patients suffer from disturbed rested sleep. See how patients with the most severe forms of itching wake up more at night, fall asleep during the day, and feel like they haven't had enough sleep. The incidence of rested sleep is greater the greater the intensity of the itching. This graph shows the proportion of patients who refer more than 3 days of restless sleep per week. As you see, in advantage cases, it exceeds 50% of patients. The presence of chronic kidney disease-associated pruritus is clearly associated with depression. Patients with higher levels of itching score higher on the depression scale, such as Bex, and more frequently they use antidepressant drugs. Patients with severe itch were more likely to be hospitalized for cardiovascular events, infection, and skin-related complications than those not bothered by itch. You can see in this graph, which also comes from the DOPS study, in which more than 20,000 patients were included. The higher the intensity of the itch, the higher the incidence of hospitalization in all these fields. Finally, and as the most serious finding, the most severe forms of CKD-AP are associated with an increased risk of mortality among patients in hemodialysis programs. In this study by Norita, with almost 2,000 prevalent hemodialysis patients, it was found that suffering from pruritus in the most severe forms have a worse survival and very marked differences over patients with mild or moderate itching. So far, we have seen information on the prevalence of CKD-AP and the impact that this pathology has on hemodialysis patients. Now, it is important to know what can we do to improve this situation. If we were able to reduce the pruritus associated with chronic kidney disease, we could improve the quality of life of our patients, the quality of sleep, the mood, and we could reduce hospitalization rates and improve survival. There is very interesting scenario before us with a long journey. The first thing we must do to improve the prognosis of patients with itching is to better diagnose it. Remember that we said that nephrologists underestimate the incidence and that only 40% of patients reported itching to the nephrologists. I believe that nephrologists must be proactive when asking patients if they suffer from itching, and we must have tools that help us to grade the intensity of itching. In this regard, various scales such as Skindex-10 or the 5D have already been validated for use among patients with chronic kidney disease. In the current management of CKD-AP, we must approach the patients who suffer from this problem, and we are going to do it with a series of questions like the ones that appear in this slide. How severe it is that it needs to be treated, how much of the body is affected, and all these ones. As current nephrologists, we must ensure that each patient receives the appropriate dialysis dose, uses the best systems to purify uremic toxins, such as high surface and permeability filters, ultra-pure water, online hemodiafiltration, filtration, and has controlled the key players in bone mineral metabolism, as calcium, phosphate, and serum PTH. We must also encourage the use of moisturizers every day. If this is not enough, we should now proceed to the prescription of some specific treatments such as topical emollients, oral or systemic treatments such as antihistamines, gabapentinoids. Finally, we can use phototherapies such as VV-UVV or NV-UVV. Finally, in this graph, it appears for the first time a drug that will soon be available and that will represent a before and after in the treatment of itching associated with chronic kidney disease, as this product has the name of difenycofalan. Most of these agents do not have specific indications for CKD-AP. They are drugs that are used for some types of itching, such as allergic, neuropathic, or psychogenic. The most widely used drugs are antihistamines by different routes of administration, corticoids, or gabapentinoids. Current clinical guidelines do not recommend the use of antihistamines for pruritus associated with chronic kidney disease. They do not recommend it because there is no evidence that its use is associated with a lower intensity of itching. The benefits that they could produce seems more related to the sedation they produce than to any specific mechanism of itching. Therefore, its use in CKD-AP is not recommended currently. Commonly used gabapentinoid drugs are gabapentin or pregabalin. It is necessary to adjust its dose in patients with chronic kidney disease due to its toxicity. These drugs have sometimes been used to treat CKD-AP, but evidence regarding the use is scant. Despite antipruritus activity, there is a lack of evidence for long treatments with gabapentinoids, and the adverse event associated with gabapentin might limit its use in CKD-AP. These effects include neurological events such as dizziness or somnolence, weight gain, angioedema, and increase the suicide risk. In this scenario, it is interesting to say that new drugs are going to be incorporated in the coming years, some of which already have very advanced clinical studies. Difenycofalan and nalbuphine are the closest to the commercialization. Specifically in Europe, the drug that will probably be used next year will be difenycofalan. It is a small hydrophilic peripherally restricted peptide. It has shown strong activity and a long duration of action in animal models. It is highly soluble in water and does not pass through the blood-brain barrier. Therefore, it does not penetrate in the central nervous system, a very important circumstance that as it avoids adverse neurological effects. Difelikefalin is a selective kappa opioid receptor agonist with no identified off-target activity. TFK binds to kappa opioid receptor with high selectivity. Its use has not been associated with typical opioid side effects such as dysphoria, sedation, constipation, or diarrhea. TFK treats CKD-AP by activating kappa opioid receptors on peripheral sensory neurons and immune cells. Activation of the receptors leads to a direct suppression of the itch signal. Furthermore, it is thought that this drug regulates the response of C fevers to pruridogens. At the immune system, DFK reduces the secretion of some pro-inflammatory cytokines following the primary human macrophages. Difelikefalin is available as an intravenous formulation that is administered at the end of each hemodialysis session. This route of administration ensures adequate compliance and does not imply a greater burden of disease or drugs for patients. Plasma concentrations of DFK are considerably reduced during each hemodialysis sessions. Therefore, it is necessary to administer at the end of dialysis session. So far, 2 major studies have been carried out under the names CALM-1 and CALM-2. The first of them were carried out in the USA, and the second was a multinational study. Patients received DFK or placebo 3 times a week for 12 weeks, with a subsequent extension of 52 weeks. This graph shows the percentage of patients who reported a significant improvement 3 or more points in the Winnie NRS score at week 12. There is a significant difference between the percentage of patients who achieved this by receiving DFK versus placebo. It should be said that a significant number of patients treated with placebo achieve a significant reduction in itchiness. This has its reasons for being, since pruritus has a multifactorial origin, as we saw before, and just for knowing that patients have been treated with something or participating in a study may be reason enough to improve. In the extension carried out during the following 52 weeks, it was possible to verify that both patients who received DFK from the beginning, as well as those who during the double-blind phase received placebo and later switched to DFK, had the same response rate in the control of the pruritus. The beneficial effect on the control of itching occur both in patients who have not previously received any treatment for itching and those who had previously received some medication for it. Furthermore, a good correlation was found between improvement in itchiness and improvement in the sleep quality. This graph shows how both variables behaved throughout the 12 weeks of the initial study, and as you can see, the morphology of the bars is similar on the pruritus and in the sleep quality of sight. Whenever a new drug appears from any pathology, it is very important to have a safety analysis evaluating the possible side effects and the percentage of patients who had to abandon the study for any reason. As you can see, adverse effects were generally rare. Diarrhea, nausea, and sickness were the ones that appear more times, with little differences from the group that received placebo. In the extension to 52 weeks, the percentage suffered a small increase. Studies with difelikefalin also demonstrated no abuse potential and no signs of physical dependence. It is important to be aware of those possible side effects, as this is a kappa opioid receptor agonists. No euphoria, hallucinations, or dysphoria were observed. All this would be related to the fact that its mechanism of action is located at the peripheral level and does not cross the blood-brain barrier. So, in summary, the clinical efficacy and safety of difenylifaline, I can say that it produces a significantly greater, more clinically meaningful and persistent improvement in itch when compared with placebo. Greater improvements in itch-related quality of life were observed. This drug should be used by the intravenously way, and the most frequent adverse events associated with this drug include gastrointestinal events and dizziness. Proactive identification is very important for nephrologists for alleviating the burden of CKD-AP. An effective communication with patient is a key to understand the burden of the symptoms, the effects of CKD-AP on patients' quality of life, and which treatments are most appropriate. Effective treatments can be improve overall patient experience. And finally, there's a new drug coming to our lives that probably will change the life of patients on dialysis with chronic kidney disease associated pruritus. Thank you very much for your attention.
Thank you very much, Mr. Sanchez, for your very interesting presentation. Also, this presentation, we have some questions. Let me look.
Well, there's a question about iron for my colleague, and it is about dialysis at home.
We do that later on.
Okay.
Do you allow people who do dialysis at home? Or that's that question. Okay. In the chat function, there are questions. Yes, I will look. A better communication between doctors and patients could improve the knowledge about the effect of uremic protein in kidney patients. How can we do that?
Well, it is important to come near the patients and talk with them. A patient on especially on hemodialysis, are people who come to hospitals one day after another for months or years. So any doctor or nurse has time enough to talk with them. And many times we talk about simple items, and it is important to ask them about itching. Sometimes we feel frustrated because we do not have appropriate tools to diagnose pruritus, and also we do not have appropriate drugs to treat pruritus. So it is important to diagnose it, to have tools to diagnose pruritus, and also it is important to have new drugs to treat this problem. The difenylifaline will probably help us to treat, and probably we move to a more frequent diagnosis of CKD-associated pruritus.
At what time is it possible to use for by patients the new drug?
It depends on the European Agency for Drugs and also in the National Agency for Drugs, but it is expected that during 2022 we could begin to treat patients with difenylifaline.
Okay. Next question. One of the challenges with this symptom is its subjectivity and the hesitance of the patient to report it. Do you believe more patients will be encouraged to speak about it and physicians more willing to treat it once a product reaches the market?
I completely agree with this commentary because when we are aware of a problem and we have solutions for it, the more frequent we ask patients or patients feel that there are a solution for the problems. But doctors, physicians should be proactive asking patients because sometimes patients do not think that itch is related with a chronic kidney disease or with a hemodialysis treatment. So they ask general practitioners about that. The general practitioners give patients antihistamines or gabapentinoids or something like that that are not appropriated, as I said before, to treat these patients. So it is important for us to be proactive, and probably later patients will come to ask, demanding a solution for the problems they have.
Okay. Next question. The problem of pruritus is often underestimated in kidney patients, but when the patient suffers severe nocturnal itching and affects their sleep, it affects their rest, and that affects their quality of life. Do you think that a good treatment of uremic pruritus could impact in the quality of life of your patients? You have already said that.
Yeah, I said that, and at the moment we have studies that demonstrate that treatment with ethylencephalin not only improves itching, but also improve the quality of sleep. Probably we will have more studies related with the follow of how the quality of life improves after the beginning of this treatment.
Yes, and a question follow up. Can it also affect the emotional health of the patient? You already.
Yeah, it is something emotional, and sometimes patients, well, there are many problems that cause itching. So again, I think it is important to talk, to try to give the patient some words or to something that they feel that physicians are doing something to improve the situation.
I know myself that for some patients is one of the biggest problems of chronic kidney disease, the itching, the everyday itching.
It is very important because those patients with severe forms of itching feel really very bad, with a very bad quality of life and quality of sleep. They feel very embarrassed and annoyed. And at the moment, I do not have a really good solution. I am really looking forward to these new treatments in order to improve not only itching, but the quality of life.
Thank you. At this moment, there are no more questions. We still have a question for Mr. Bandari. Do you allow people who do dialysis at home to look after their own intravenous iron, or do you ask them to attend the hospital?
So initially, we allowed them to give their own intravenous iron at home because they couldn't understand why things would change because of the new guidelines about safety. So they signed a waiver to say they were happy to take that risk. But that has changed in the NHS. So they have to come once every 3 months for an intravenous dose of iron now, which we give them during one dialysis session at hospital.
There is still one more question. Can kidney transplanted patients experience these symptoms?
Oh, absolutely. Especially post-transplant, they're usually quite anemic, and quite often they need iron and erythropoietin in the early stages. And it depends on how well the kidney functions, of course, because we use a lot of kidneys from what we call marginal donors, and we also use deceased donors who are what we call heart-beating death donors. So they often might need long-term ESA therapy or intermittent iron therapy.
But how do you know if your iron in your blood is good? In a normal diagnosis, in a normal analysis, it is not measured.
So I think two things to understand is, one is you have to monitor the patient. So you will never make the diagnosis if you don't do the test. But two is how you interpret it. the WHO have certain levels of defining iron deficiency which do not apply to chronic kidney disease patients. And a transplant is defined as a chronic kidney disease patient because they're on immunosuppression as well. So the levels at which you treat are very different. And that's really important when we give treatment.
Okay. Now, thank you very much. We have answered every question. And we also are in time. We reach.
Excuse me, Jan. I think that the last question was for me about the symptoms in transplant patient. It was said that the question was for the doctor.
Oh, okay. Oh, sorry. I'm sorry. You can answer.
I just want to say that these symptoms are associated with any kidney patient, but especially in those which renal function is impaired. When you have a transplant, after some years, you can have an impairment in renal function. And in that situation, again, those symptoms associated with the impairment in renal function could appear. So itching, pruritus could appear in transplant patients again. Thank you. I'm sorry for this.
No problem. No problem. At this end of this webinar, I want to thank the two people who talked us about everything, Dr. Bandari and Dr. Sanchez. I will thank you very much for this, for your presentation and for answering the questions. And I will also thank EKPF making it possible, and also the sponsors by whom it was possible that we had this webinar. Thank you very much, and maybe we can see you in the next webinar.
Okay, thank you very much. It was a pleasure for me to participate in this meeting.
Okay, thanks.
Bye.
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 Bye.